before we even talk about PI-RADS, let's just look into this, and you're not surprised with the just exponential growth of prostate MR over time. And most of you guys know are ordering these exams, so it's not a surprise to you, but it's really exponential. All right, so before we talk about PI-RADS again, let's talk about basics. The multi-parametric term comes up. And that's all that is different sequences that are used when we obtain MRI. So diffusion, you've got T2 weighted sequences, dynamic contrast, and then T1 is also done. So basically, putting the puzzle together gives a better picture. Anatomy is best seen on T2 weighted images, and then diffusion basically is diffusion of water within the location that we're imaging. And vascularity has to do with angiogenesis of the cancer. So for zonal anatomy and periprostatic tissues, it's nice to see the T2 weighted images that you can see the peripheral zone, urethra, and the TZ in the center, which is a big problem today in imaging. But peripheral zone you can see nicely, right? And then the anterior fibromuscular stroma anteriorly. So if we look at the zonal anatomy a little bit, you can see that the peripheral zone is in the posterior part and goes a little bit anteriorly. Bladder at the very top there, and BPH is causing the transition zone to extend up. And you've got nicely the peripheral zone transition, and the rest of we'll go into the anatomy. Most of you guys know this, but I wanted to go over the basics. So peripheral zone is primarily glandular, and it's posterolateral component of the gland mostly. And the transition zone, obviously, is where all the issues occur in prostate MR because it's so variable in shape and size. So typically, you can see the two lobules, but as the BPH increases, it can get quite chaotic. But you can still follow the nodule. So if you go superior to inferior, you'll be able to follow, and the so-called organized chaos is what that is. But you can follow if you can draw the lines around it. But what happens with this extensive BPH is the peripheral zone gets extremely attenuated. So as you can see in blue, you can barely see the peripheral zone. You can imagine a small tumor that's plastered against a BPH would be so difficult to evaluate. And if we look at the zonal anatomy on coronal images, you can see, again, we can evaluate the zonal anatomy. And here's central zone, which was originally lumped with the transition zone. I'll go over this a little bit more in the next few slides. Here's the seminal vesicles, again, transition zone coming in, then prostatic urethra. So anatomy, as you can see, is well seen on T2. What about cancer? So as we've seen, peripheral zone is bright. This large mass, obviously, is a typical cancer, and usually they're not so large, but just to give you an example of what that would look like, in the transition zone is where the issues are, and as you can see, if you can start looking at the glandular anatomy of the transition zone, you can often see the transition and see this homogeneous low signal, or it could be more lenticular in shape, but typically it's going to be homogeneous, ill-defined margins, and it can involve the anterior fibromuscular stroma. Or the so-called erased charcoal sign that we discussed is typically, can be anterior, posterior, but you look at the rest of the anatomy of the transition and you'll be able to pick out the differences. Also, the neurovascular bundles are these black dots that you can see in the fat around that area at the 5 and 7 o'clock. But as you know, it's quite variable in different cases. So to look at we've done the anatomy. What about the diffusion weighted images? So each image element, or the voxel, is really showing the rate of diffusion of water in that location, and that's what diffusion weighted imaging is. So typically, if you have, let me go back here. If you have cells that are far apart or normal cells, you're not going to have much restriction. This is the diffusion, and this is the ADC is the apparent diffusion coefficient, which is a velocity map that's obtained from the diffusion weighted images. But if there are a lot of tightly packed cells, there's going to be diffusion restriction, which shows up as bright on diffusion and dark on ADC. So we're looking for this black and this white and black areas on diffusion to call something cancerous. So here an example of in the peripheral zone. So if you were to look at PI-RADS and just to score, if you were to look at diffusion, and PI-RADS is a Likert score 1 to 5 with highly likelihood or not likelihood of cancer. So if you were looking at this bright area on diffusion in the peripheral zone, this is ADC is black and bright on diffusion weighted imaging. This is less than 1.5 centimeter in size, and so this would be a PI-RADS 4 as opposed to this, which is a large mass greater than 1.5 centimeter, and then that would be a PI-RADS 5. So that's in the transition zone. This is in the peripheral zone. And so now if we look at vascularity, it's just tumor angiogenesis. We won't go too much on that. So PI-RADS, like I said, is a Likert score and has had several iterations over time now. It's on 2.1 version. And so what changed? So before we even, again, talk about PI-RADS, let's see where is the lesion, because PI-RADS deals with where the location of the tumor is. So if we were looking at this again, in this example, you see the transition zone, you see glandular changes, BPH, peripheral zone, and you see a mass right here. So that would be in the peripheral zone. And here you see the other image right here, the transition zone, and you see focal, homogeneous, ill-defined, low T2 signal mass, right? So that is in the transition zone. So there's different weighting in the PI-RADS for lesions in the peripheral zone as opposed to transition zone. And so what happened in 2.1 version? So PI-RADS had several iterations, right? So we realized there was a lot of issues going on with the transition zone, so there were changes in protocol. So if you were familiar with the original, you'll see some protocol changes. So for example, let's look at an example here. So here's a T2 weighted image, and you can see there's both axial and a coronal, and sometimes lesions are better seen in one or the other. So you can see this both nicely on this image. And then if you see the diffusion, here's the ADC dark area right here, and it's bright on DWI. So this is typically a PI-RADS 4, right? Because it's less than 1.5 centimeter. What about contrast? Yes, it enhances, but contrast here doesn't add much more. Also, a sector map has been included to include the central zone. And there are a few protocol changes for diffusion to have higher B values, because to get diffusion, you use high gradient pulses, and those are B values. And let me show you for an example. So this turns out to be a PI-RADS 4, as we talked about. And also in the PI-RADS version 2.1, you can get a template. So online, you can get a template that will give you specifics to add in your report, and specifically quality is mentioned in that. So this was a 4+3 tumor. Now let's look at this example here. So here's an axial T2, coronal, you got diffusion, not very great quality, but yes, this is considered diagnostic. So here you see some asymmetry anteriorly, which you can see on the coronal view on the left. And you see a dark area on the ADC, but nothing on the DWI 1000 image. And why is that? Because this is not high enough. Because higher B values will give you more contrast between abnormal and normal. So now it's mandatory on the 2.1 version to have either an acquired or a computed B value of greater than 1400. And then DCE can be 3D T1 gradient echo, or it could be 2D as well. So the Likert score here, but so central zone is one of the areas that's been added in the 2.1 just to be a little bit more aware that these very, very rare to have central zone tumors, but they are more likely to progress. And what it appears like is dark on T2, and it has this little V shape. And then you can see that on diffusion, it should not have restriction, so there should not be much restriction, or ADC. ADC will be a little dark because it's on T2 dark as well, but it should not have high B value. And it should not enhance. So what about a tumor? Tumor will be the opposite, so you have asymmetric lesion, and that's extending to seminal vesicles, and this is a typical central zone tumor that's large. But sometimes, obviously, they're not large, and this is the asymmetric lesion that you can see in the left central zone that you may best pick out on a contrast image or perhaps diffusion. So that's why sometimes contrast can be very useful. Another thing that's been added in the new 2.1, it's not new anymore, it's from 2019, is this anterior fibromuscular stroma, which is dark on so low on T1 and T2 signal on the images. And you've got this antifibromuscular stroma that has variable shape. So that's a normal. It looks fairly dark and mass-like. And let me show you a tumor that looks very similar to it, but it's a little bit grayer than, so typically the antifibromuscular stroma, even though it's variable in shape, will be darker than the tumor. And just to give you an example, it can bulge out, the tumors can bulge out, or they can be teardrop shaped, such as this, in the antifibromuscular space. This is a large mass that is in the antifibromuscular space, and then you can see the diffusion weighted images that show the ADC that's dark and then high p-value image that's bright. The other thing that's been added in 2.1 is the measurement, and so the typical transverse diameters on the axial image and the AP and longitudinal on the mid-sagittal view. In Europe, they're not including the median lobe, but in the US, we are including the entire measurement on our images. So scoring of peripheral zone lesions, T2 scoring is different both for peripheral zone and TZ, so typically this has not changed much. Axial T2, the PI-RADS 1 is normal, T2 has some vague low signal that may be linear, and then you have some homogeneous low signal, that's 3, and 4 is where you start to worry about a lesion that's nodule right here. When it's greater than 1.5 centimeter, or if it's extending out of the capsule region, then it becomes 5. It's really the TZ that has given us most of the issues, and these algorithms, by the way, are available on the PI-RADS 2.1 version online. But the image interpretation, what has changed in the 2.1 is in the transition zone primarily. So now we're not scoring the typical BPH nodules that are well encapsulated. So if they're BPH, do not score. What's scored now is if it's a mostly encapsulated nodule, meaning part of it is not, or if there's a homogeneous area without encapsulation, or if there's an area hypointense between nodules. And let's go over an example of that. So this is typically what? So here's a typical BPH region. You see nodules. There's nothing that's on diffusion, you see, but these are well-defined encapsulated nodule. So you do not need to score this. This is 1, and end of story. How about this? Here's an example of a nodule that you can see, if you draw a line, a pencil line, you can see that this part of it is not completely encapsulated. And when you look at on diffusion, that is black and it's white. So what is that? So it's not bigger than 1.5 centimeters, so this is a 4 on diffusion. So it's mostly homogeneous, encapsulated nodule on T2. This is a TZ2, and a diffusion, it's 4. What does that do? This is now considered atypical TZ nodule, and then that upgrades it to a PI-RADS 3. So unfortunately, that has increased our PI-RADS 3, but the transition zone was an issue, and that's something work in progress. How about this example? Here's, again, it's mostly encapsulated. You're not seeing the dark line, but it's dark on ADC and not bright on diffusion. So what does that make to diffusion PI-RADS? That's a 3, right? And then this is a 2, because it's an atypical TZ nodule, and then they'll stay overall, this will be a 2. So that's a typical scoring. What about biparametric? There's a lot of data right now on biparametric, but on the 2.1 version, there's no specific recommendations for the use of biparametric. There are specific recommendations for when you use multiparametric. There were several reasons for that. One of the issues initially was that our insurance only pays once. And so if you are getting a biparametric and you knew something, you can't really change that. And the other thing was we weren't sure about quality either. Let's just look at this example. So we know in PI-RADS 2.1 even, the contrast doesn't add much except in the peripheral zone where it upgrades it to a 4. But it's when it's everyday readouts that you notice this. So when I'm with the trainees, it's the second look, or again, if even finding a lesion sometimes is helpful with contrast. And let's go over this example that was for second opinion. They had a negative biopsy, and they found an 8 millimeter lesion on the non-fused biopsy. So on here, the T2 weighted images we don't see any lesion, and a diffusion is just very, there's a lot of artifacts, even though they got a high B value. So when we look at the contrast here, it's not going to let me run, but it's okay. So here's the lesion, and you could see on the, let's see here. You can see it anteriorly in the transition zone, and that was only picked up because of the contrast. So what's the diagnostic accuracy of 2.1? Not much data there, but this was just published this year, and this was on, it's a meta-analysis of from 70 studies, over 13,000 patients that showed that the sensitivity and specificity for PI-RADS 2.1, if you include 4 and above, is about 89 to 66%. So overall, large, this is one meta-analysis. But we know that impact of MR and biopsy and frequency and outcomes has changed. And even this large Swedish study showed that there's been clear change in practice. And it's now prostate MR and MR-directed guidelines have been endorsed by major prostate cancer groups. But so the issue comes up, why have we not updated the PI-RADS 2.1? The American College of Radiology has specific objectives for any RADs that are developed. So just like PI-RADS, there are other RADs in the body, and in 2022, there were 10 RADs that had organically grown. And so PI-RADS does include, actually is compliant with all the objectives, but the update, the question is, there's not sufficient evidence to support the update, because now they have mandates specifically that, what you need is major effect on patient care. So I think that's what's lacking right now. And the biggest issue's obviously been quality, and this was amongst academic radiologists from the Society of Abdominal Radiology, where there was significant variability in positive predictive value, and imaging technical quality as well. So both steep learning curve and the image quality has been an issue in the US, and that has really brought up the biggest challenges of increased images, false positive exams, and PI-RADS 3. So the American College of Radiology has now come up with specific guidelines and quality issues that are now being brought out. This is something I was involved in earlier. This has been going on for like past 5 years now. And this does include some personnel qualifications, a little bit of RAD path correlation. We had originally started to work on centers of excellence, but this is what we came up with because we just couldn't have nationally. We didn't have enough RAD path correlation exam people, especially private practices that could really apply for that. So that's what we are right now at. And this is where all of the prostate cancer designation centers are available today. So ACR has specific things that we are involved in. MR training specifically, you can this is available for anyone online. You can do free registration and get the PI-RADS primer. You can also do online training. There's also 2 days this had stopped during COVID, but has restarted, where you can do 200 cases with RAD path correlation. We go there for 2 days and interact, and people come from all over to learn. But I think the most important, and I think the best part, is this collaborative that started from the ACR. And what this is, it creates a group within your system, and this is led by Andre Prisco. And what it is you'll have radiologist lead, you'll have MR supervisor or manager, technologist, scheduler is involved, and a physician representative. So I think this whole multidisciplinary team within prostate imaging is really key, and right now they're at the 5th cohort level and have had good positive results. This is part of quality initiatives from ACR from 4 different systems: breast, lung cancer screening, and prostate is one of them. So I'm really glad that this is happening today. So in conclusion, I think 2.1 is performing as expected. We have higher prevalence of clinically significant cancer, but there are limitations. And I think the whole focus is on quality assurance at this time. So thank you very much.